I will talk very basic today, inshallah, how to evaluate and assess the bone health in our CKD patients. It's to be honest, it's this knowledge is not very well established. We still need to do a lot at both the clinical and research basis to improve our performance and our knowledge about this subject. I have to say that I don't have anything to disclose. I don't get any money or don't have any pharmaceutical industry relationship when it comes to bone. I have some multi-center randomized clinical trial, but none of them are related to bone, so I don't get any money, and I am not paid for this session. The objective of this study is try to understand the mechanism of bone loss. We are all talking about the bone disease in our patient, but we need not only to scratch the surface, but to dig deeper and understand what's going on our patient's bone. And one of the major concepts that I want to leave you with today is the concept of not only the bone quantity, but the bone quality. Because everybody in nephrology and in bone medicine and surgery are focusing mainly on bone quantity, bone mass, bone volume, but we don't focus too much on bone quality. So I'll give you some example how to assess and evaluate and improve bone quality as well. If we have any time left, I will just touch with the pharmacological and maybe non-pharmacological intervention that we can do for our patient. I'll start with a question. Once upon a time, there was an anthropologist. Her name is Margaret Mead, and one of her students asked her, what is the first sign of civilization? So she takes care of, and she teach her student the civilization, ages of human civilization, the Ice Age, Stone Age, the Agricultural Age, Industrial Age, whatever. And she was asked this question: what was the first, initial sign that people start to organize and start the civilization? Of course, she is an anthropologist. If you ask, another expert or leader or any other person, he can answer this from his own perspective. But she said the first sign of civilization is to heal a fractured femur, to heal a long bone. Because in the animal kingdom, if you fracture your long bone, you're dead. It's a death sentence, because you will starve, you will die from hungry, from sunstroke, or from frozen bite. Nobody can give you anything, or animal, they are smart, but there is no animal can bring water or food or take care of another animal. Especially the fractured femur takes about 4 to 6 weeks at least to heal. So if you stay in outdoor for 4 to 6 weeks without food, without water, you're gone, you die. So the first sign of civilization is to have somebody else to take care of you, to heal your fracture, to feed you, to give you a drink. Then, after 4 to 6 weeks, you have, the recovery from this fracture, then you can take care of yourself. This is how important our bone are. We cannot live, at least functionally or normally, without having strong bone. By the way, in the general population, fractures are more common than strokes, heart attacks, and breast cancer, which is one of the commonest cancers, especially in women. If you combine all of these morbidities, the fracture risk is higher than all of these diseases. The consequences of these fractures are terrible. And these are in general population. What about CKD patient? As you see, with declining of kidney function, you have higher risk of fractures, up to 4 or 5 folds. And CKD stage 4 and 5, including dialysis patients, they have at least 4 or 5 folds higher risk of fracture. Not only that, but also the consequences of fracture in our dialysis population and CKD population is terrible. If a general population, man or woman, fracture his hip, he has 20 to 25% chance of death within the first year after experience fracture. In CKD patient, this might be double. About 40 to 50% of our dialysis population, when they fracture their hip, they die. So this is a major problem. To live normally, to be functional, you need a strong bone. And to have a strong bone, you need to be active and you need to be functioning. So it's a vicious circle. If you stop moving, you will have weak bone, then you fracture, and when you fracture, it will affect your mobility and activity and vice versa. So it's very important to have good quality of life. You should have good bone health. Here is some consequences of fracture. Fracture is not only a medical problem, it's an economic and social problem. See a dialysis patient, when he fractures his hip or vertebrae, I see this all the time. Patients comes in driving, they are independent, they live by themselves, they go, cook, they go, and do shopping and everything. Then all of a sudden, they sleep in the bathroom or in the kitchen, and they have a traumatic or low trauma fracture. And after that, all of their quality of life, it changed dramatically. Even if they used to take care of kids or other family members, now they need somebody to take care of them. They cannot function. In America, we put them in rehab, in short-term and long-term units. Some of them, they stay in the unit for forever, and there is economic burden of that. And of course, the death rate is much higher. The good question is how to know that your bone or your patient bone is strong. I mean, to check your heart, there are several non-invasive and invasive tests, right? You can do up to an angiogram and inject a dye and go with a catheter and check on your heart. There is a stress test, stress echoes, and stress thallium scan or whatever, What about bone? Is there a stress test for the bone? Can you do invasive test for the bone? The information that we are getting from the bone is almost indirect. All the tests and investigation we are doing for our bone health is indirect. There is no actual good surrogate marker. Maybe the only good marker is a bone biopsy, which is an invasive technique, and a lot of patients, they don't like to have this invasive procedure. It's minimally invasive, but still, patients, especially it's painful. We were struggling to get patients recruited. Tomorrow, inshallah, we will have a workshop with bone biopsies, and we struggle, Dr. Nihal and the rest of the team struggle to get patient, consented for bone biopsy tomorrow. And we face the same problem in America. Is there is any other non-invasive test can help us, because we are not going to do bone biopsy for every single patient. Technically it's very hard, even if the patient agreed. Okay, so we need non-invasive tests. We need better surrogate marker to tell us how our patient's bone behaving. Ideally, if you want to check the strength of the bone or the bone health, you put a tension, you put force, you put a stress on the bone, and you see how the bone reacts to the stress or the force or the tension. But this is very hard to do, in our patient. We can do this post-mortem, we can do it in vitro, but it's very hard to do it on patient. Our bones are in a constant state of compression and tension all of the time, depending on the place and the position and the anatomy of our bone. So there is tensile forces and compression forces, and there is ways to do that in our lab, but not on our patients. I will give you an example. This young, this nice lady who is trying to help her husband and trying to check his height. So she stood up on this stool. She is a little bit obese, and this stool might not be strong enough to carry her, so she might have a risk of fall. Here is a concept of bone quantity and bone quality. The denser the structure, the denser the seat, the denser the chair is basically or technically the stronger it is, right? But it's not only that, it's much more complicated than that, because also there is structure in this seat or chair. So the hinges, flanges, the connection, the structure also helps in the strength of the chair. So this chair or the seat on the right side here, it's a steel, so it's more dense. If you put it under DEXA scan or X-rays, you will see it as whiter because it's denser. The other chair is wood, so it's less dense. Okay, so technically speaking, the first one, the steel one, is denser, so it's probably stronger. What if we take out these connections, the hinges and flanges, from the steel chair? It will be weaker compared to the wood, which is less dense. Same thing in our bone. To have a strong bone, you should have dense bone, good quantity of minerals in your bone. So when you do an X-ray, you see your bone is white, your DEXA scan looks good with the T and Z scores and stuff, but also the bone structure. And this structure has different levels. It can be macro structure, macro architecture, and micro structure, micro architecture, and nano structure and architecture, right? So we have to make sure that we understand this concept. Is it only quantity or also quality? And we were having discussion with Dr. Ayman 10-15 minutes ago about the graduates of our schools or colleges. We are graduating 100,000, right, of college students. Is this achievement? Of course this is achievement. The number is good, but also the quality of these graduates might be as important or more important than the quantity. There is no single university or college in America or in the Western world that graduate hundreds of thousands of students every year. This happens here. We don't have problem with the quantity, but we have problem with the quality. So here in the bone is the same thing. And you can read it. You can. It's the same thing. Opportunity is nowhere, or opportunity is now here. It's the same letters, same words. The way that you interpret it, the way that you read it, make the difference. When I was little, we used to hear this story. When this old guy is about to die, he collected his kids and he wants to leave them with something. And this something is he have to be united. And the number is important. So he gave them, every one of them, a stick, and it was easy to fracture. But when he, gave them a big number of sticks, they cannot, break this. So quantity is important, but also it needs unity and teamwork to work on, because this guy, he is only one, but he worked on himself. He has, he is stronger. He can beat a lot of other, weaker guys, especially if they are not organized. When it comes to osteoporosis, same concept happen. If you ask any one of us, what's osteoporosis? He or she will say that osteoporosis is low BMD, T-score minus 2.5, right? That's the operational definition, but this is actually not the real definition of osteoporosis. Osteoporosis is more complicated than that. It's much deeper than that. Here is the WHO definition. We have two definitions of osteoporosis. We have NIH definition and WHO definition. So the WHO definition, they defined osteoporosis as a skeletal disorder, okay? Systemic skeletal disorder characterized not only by low bone mass, which is whatever bone mineral content, bone density, T-score, Z-score, whatever you want to say, but also microarchitecture deterioration, which is very difficult to word. What's microarchitecture deterioration? And this is very old. This is 1993 definition. I'm not talking about 2021 definition. It's the established osteoporosis definition several decades ago. But do we understand in 2021 what is this microarchitecture deterioration? And of course, by the end of the day, you need to prevent the fracture. You need to have strong bone, because fracture is a bone attack. Like if you have heart attack, right? There is primary prophylaxis, secondary prophylaxis, and tertiary prophylaxis. You don't wait till patients get heart attack, then you deal with the consequences, right? You start to prevent heart attack from happening, because if heart attack happens, this means that probably this patient has part of his myocardium or his heart is dead, right? Same thing here. If you wait till fracture happens, you're too late. So the idea is try to prevent fracture, try to improve your patient survival and the quality of life. So we need to focus on two components, not only on one component, which is the BMD, but also on what is what they said about microarchitecture deterioration. Everybody's saying that the DEXA scan is very easy to interpret and to do, and it's affordable and very public thing. And we know -1 is osteopenia, -2.5 is osteoporosis. But the major thing is the majority of fracture happens in non-osteoporotic BMD. We used to call it non-osteoporotic patient, but by the definition, osteoporosis is not only BMD. I mean, so technically, majority of fracture happen with patients with a T-score of more than -2.5. We are focusing on this. Of course, if you have less than 2.5, your chance of having fracture is much higher. But still, about 60% of postmenopausal women, they fracture with low trauma fracture or atraumatic fracture or pathological fracture, even with BMD above -2.5. Here is the other definition, the NIH definition of osteoporosis. They said it's a skeletal disorder characterized by compromised bone strength, predisposing to increased risk of fracture. And they said bone strength is primarily reflecting integration of bone density and bone quality. So to have a strong bones, you need multiple things. You need to have a good mass that contribute about 50 to 60% of your bone strength, but you also need good bone cells, the osteoblast, the osteoclast, the osteocyte. All of these cellular activity has to be normal. Then you need a good microarchitecture, macroarchitecture, nanoarchitecture, whatever you call it. Then you need to have a combination of good matrix and mineral, because bone is not only minerals. Minerals is an inorganic component of our bone. So calcium, phosphorus, hydroxyapatite, all of these minerals are the inorganic component. but also you have the organic component, the matrix, which is a protein type 1 collagen that is coming out from the osteoblast. Okay, so a combination and integration of both the matrix, the protein part of the bone, and the mineral part of the bone are very important. So bone density explain about 60%, but bone quality explain at least 40% in general population. And when it comes to CKD patients, because CKD patient, as we know, that we focus on three things, something called T and M and V. T is for turnover, and M is for mineralization, and V is for bone volume, right? So the volume or the mass is the density. But what about turnover? Because, you know, in our patient, we know that the majority, they have a major problem with bone turnover. Now, majority of our patient has low turnover bone disease, by the way. It's more common than high turnover bone disease. So the balance of turnover in our patient is very hard to achieve, and they are on either, you know, sides of the spectrum. So bone quality in our patients is a major part. Bone quality in general population explain 40% of bone strength, and in our patient explain at least 50%. And this is the way that I just told you that most of the fracture happened in non-osteoporotic BMD. Can we measure bone quality? So bone quantity, we know I'm not going to teach you how to do DEXA scan, you know, QCT scans, and how to even X-ray. We used to diagnose, or not me, maybe Dr. Sobha or Dr. Nagy, used to diagnose osteoporosis several decades ago by plain X-ray film, right? They see the density of the bone before the invention of the DEXA scan 3 decades ago. Can we at least get some information about the bone quality? Yes, we can, but we just need to put some efforts. First thing is there is something called bone turnover markers. It's non-invasive, and it's just a blood or urine test that you can do. Then there is invasive tests, including bone biopsy. Then there is imaging technique, and I'm going to focus today on something called TBS, or trabecular bone score, and I'm not going to talk about other more advanced technique that it might not be available here. We published these 2 articles a couple months ago with very nice co-authors, including Mamdouh, Mohamed Abdelbari, who is famous here, Mamdouh, and the rest are our part of our team in Kentucky. And it was 2 parts article. The first was focusing on diagnosing and the concept of bone quality in CKD patients, and part 2 was focusing on management. So please, if you are interested, you know, Google it and find these 2 articles. Was published in Kidney Disease Journal a couple months ago. There is a lot of information. And here is one cartoon that we included in this article. You see many tests, and I don't expect you to understand or to deal with all of these tests, but at least I'll give you some examples of that. Then if you're interested, go ahead and read it. Also in this article, in article part 2, we focused on management and on the mechanism, because to manage, here is the thing, because most of people when they manage bone disease in general population or in CKD patients, they manage it almost blindly, especially orthopedic surgeon. And I hope that we don't have any orthopedic surgeons here, because they treat osteoporosis. They do a bone density scan, the DEXA scan. Then they find the patient has low BMD. Then they give whatever bisphosphonates or vitamin D or calcium or whatever. But they don't know exactly what is the mechanism behind osteoporosis. What is the definition of osteoporosis? They just do everything based on BMD. Then they put the patient on bisphosphonates for several years. The problem with medication that we use in bone, it's not a week or 2 weeks or a month of therapy, right? You have to put the patient on these medications for years. Then if you're going to do evaluation for the bone, you're not going, most of our regular practice, at least here in Egypt, they put the patient on, say, bisphosphonate, then in a year or two, they repeat the DEXA scan. It doesn't mean that DEXA scan improves, that bone improves, okay? It's just, it's a marker. It's like BSA, for the prostate. Doesn't mean that you have high BSA, that you have, benign prostatic hyperplasia. You might have something different, right? So it's not 100% specific or sensitive. It's popular, it's cheap, low radiation exposure, it's available everywhere, and it's very informative, to be honest. It gives you at least 60%, as we discussed, of the bone health, but it's not the only thing, especially if you are treating the patient with medication that are not free of side effects. The patient can have complications. Actually, some patients, when they bought them, if the patient already have low turnover bone disease, and if you give the patient bisphosphonates, you will induce more harm than benefit. So it's better before you start the medicine to understand what is the mechanism of bone loss. Here it might be very complicated slide, but especially in our CKD patient, you see here the bone surface, you see here there is an osteoblast. Osteoblast usually works together as group, as soldiers, hundreds of them, back to back, shoulder to shoulder. Then you see this single cell, which is like a tank or something very big, very active, biologically active, and it works by itself. It's called osteoclast. Osteoclast, it just lives 3 to 5 days. It's very, short-lived, and it's very biologically active. It has 5 to 20 nuclei. It tries to do its effect or its job just in 3 to 5 days before it dies. So try to resorb the bone very well. Then it takes a long time for the osteoblast to come lined up and start to build up the bone again. This process is very important. It's physiologic. Without this, we call it bone remodeling, or bone turnover. Without this bone remodeling cycles, the bone will be dead, will be like this wood or this steel. Okay, so we have it's very functional, living tissue, and there is all the time there is bone remodeling. So what happened here? And our patient, when their kidney function goes down, one of the first thing happen is there is something called osteocyte dysfunction. We know the osteoblast and the osteoclast, right? Osteoclast is bone resorbing cell, osteoblast is bone forming cells. And there is, you see this cell, which is, it used to be an osteoblast, but osteoblast build up bone, then it get trapped inside the bone. So it changes the structure and function to something called an osteocyte. Osteocyte is one of the major endocrine paracrine system in our body. So it starts to secrete molecules and hormone that controls not only the bone, but also the whole body. It's very important cell. And major part of our CKD patients is the osteocyte dysfunction. When osteocyte get this, dysfunctional because of the CKD, start to secrete more molecules like FGF23, and most of us, we know what is the impact of having higher FGF23 on the heart and cardiovascular disease. Then start to secrete sclerostin, and sclerostin inhibit wing signal and inhibit bone formation. Then the BTH itself, is start to increase at the beginning as an adaptive mechanism. We like to see higher BTH at the beginning in the CKD, not too much, but because it's just adaptive. It might change from adaptive to maladaptive, okay? Actually, BTH is very important to our bone because it stimulates our bone. It stimulates the bone remodeling cycle. If you don't have bone resorption, you will not have bone formation, okay? So it stimulates the bone resorption. And it does that because it actually works not on the osteoclast, but on the osteoblast. It increases something called rank L secretion from the osteoblast, which is nuclear factor kappa B ligand that goes, it comes out from the osteoblast under the influence of the BTH, and it goes to the osteoclast. There is rank receptor on the osteoclast, so it stimulates this receptor and stimulates all the osteoclastogenesis cycle. Depending on these mechanisms, we'll have a lot of interventions, including anti-sclerostin antibody to improve bone formation, including BTH to stimulate bone formation, including the SERM or selective estrogen receptor agonist or modulator that actually increase something called osteoprotegrin. Osteoprotegrin is the decoy of the rank L. Anyway, I know that it might be complicated, but at least most of us are in CKD management. We focus on this thing, the phosphorus, the BTH, which is just the service of the disease, but we don't focus on all of, and this is what we know, or at least clinically we know we can measure. And now we have treatments. I'm not talking about theories or basic science here. This is actually every one of these we have already either monoclonal antibody targeted therapy or all the therapies like bisphosphonates that works on the osteoclast, increase osteoclast apoptosis, and so on. So we are talking about medicine that we can use in our CKD patient to improve their bone health. We are not talking, most of nephrologists focusing here on vitamin D receptor agonists, the calcium mimetics, and controlling the phosphorus with phosphate binders and the food, but just a few are digging more and try to see exactly what's going on in our patient's bone. Okay, let's focus on one simple thing, and please try to stop me at any time if you have any question or if you don't understand anything, or if I am getting very boring. Okay, I don't want to be boring, and I know that most of you might not be familiar with this knowledge or might be advanced, so I don't know. So please, I want to make it interactive. If you have any questions, stop and ask and say, this doesn't make sense. Can you explain it? Whatever you want to say. Okay. So we talked about DEXA scan. DEXA scan is very popular and easy. I want to keep you also with this concept. You can add in the software, instead of only getting the BMD, the bone mineral density, bone mineral contents, and the T-score and Z-score, the software they can add to the machine, and this software can help to assess the bone microarchitecture or the bone quality with something called TBS, trabecular bone score. Trabecular bone score, as you see, this are two persons with the same BMD. When you see the bone with X-ray or bone density scan, they have the same identical BMD scoring. But if you look to the vertebrae here and see the microarchitecture with using something called trabecular bone score with the DEXA machine, you can see they have very different microarchitecture. This vertebrae is much worse compared to this. This is organized, the trabecular are organized. The hole or the bores here are smaller. This is more porous, and also the trabeculae is probably more fragile and thin, and they are not connected well. So TBS here, TBS, you're familiar with the BMD. They give you a similar picture of that, right? If it is minus 2.5 or less, it will be in the red zone. If it is between -1 to -2.5, it will be in the yellow zone. If it is above -1, it will be in the green zone, which is normal, right? Same thing here with using this TBS, which is just a software that you can adopt. If you have a machine, you can, add it to your machine and give you some impression. If it is more than 1.4, it's good. If it is less than 1.2, it's bad. And in between 1.2 to 1.4 is the gray zone. Exactly, it's trabecular. So as we know, very, very smart question. We have compact bone and we have trabecular bone on cancellous bone. The compact bone is the cortical bone, which is the outer layer of the bone. It's getting more denser and thick in the long bone. And this has a wisdom in it. Why our vertebrae has more trabecular, cancellous bone, compared to the long bone. Exactly. It's like shock absorbers. يعني انت في العربيه عندك بتبقى عندك shock absorbers صح اللي هي الايه مساعدين. فالبون بتاعنا الفرتبري او السباينز بتاعتنا has the same يعني concept. It has to be compressible. It has to absorb the compression. But in long bone, if you don't have a strong long bone, you have bowing your legs. So you need more cortical here. You need in the vertebrae or the spine more cancellous or trabecular bone. So it's a trabecular bone. So the trabecular bone is mainly in the spine. So it's only done in the spine, right? And here is very good example with what's going on. Here is the patient with osteoporosis, right? This is normal. If you have normal quantity and quality, the risk of fracture is very low. If you have osteoporosis by BMD, low BMD, less than 2.5, minus 2.5, and poor bone quality or poor TBS, okay, less than 1.2, you will have very high chance of fracture. This green, this is red, right? Color tells. But I want you to focus on C and D. Both have the same, almost the same color. The C is a patient with low BMD, right? Minus 2.5 or less. And this one doesn't have, it has okay BMD, it's in the osteopenic range, from minus 0.1 to minus 2.5, but still have almost higher chance of fracture because it has poor TBS. So a combination of TBS with the BMD gives you more information and it improves the fracture risk prediction of our patients. Okay, very simple technique. You're not adding anything. The spine بس صح ما في على اللونج بون. ممتاز. مش بس كده. It's not only for diagnosis but also for follow-ups because some medications they have preferential differences when it comes to medication. Some medication improve bone quantity more than quality and vice versa. So if you give BTH, for example, teriparatide or abaloparatide, which is BTH-RB, it improves the BMD about 10%, but also it's very good for the bone quality, almost 4 or 5% improvement. That's good. Denosumab, which is a monoclonal antibody against rank L, it improves the bone volume or bone mass about 8% and improve bone quality a little bit about 2.5%. But if you see bisphosphonates, which is the most widely used anti-resorptive therapy, it improves the bone quantity by about 5%, which is good. But what about bone quality? It's very poor, less than 1%. Okay, here is a hormonal replacement therapy and the SERM. It can improve bone quantity, but it doesn't do, it might actually worsen the bone quality or the TBS. And these are the effects of corticosteroid. It doesn't actually do very bad impact on the bone quantity, but actually on the bone quality. And here is the anti-androgen therapy. It affects bone quality more than bone quality. So this concept of don't only be focusing on the BMD or the bone mass, but also focus on bone quality. And because of now we have much more medicines than we used to have 10 years ago. So we need, before choosing our medicine or approach, either non-pharmacological or pharmacological intervention, we need to know exactly what's going on our patient's bone. As anti-resorptive therapy, so if the patient have higher bone resorption, you need to give something to stop bone resorption, right? Like bisphosphonates, which is very common, denosumab, we talked about, selective estrogen receptor modulator, and calcitonin. And on the other hand, if the patient has low turnover bone disease, you don't need to stop the bone resorption is already poor. If you give this medication to a patient with low turnover bone disease or patient without high bone resorption, you're not going any good. Actually, you might hurt your patient. So this patient with low turnover bone disease, you need to give them something to stimulate bone formation, like teriparatide, abaloparatide, and romosozumab. Okay, so I'm going to focus now on the biomarker, how to use the biomarkers as non-invasive tool to assess our bone quantity and quality. And please tell me if I'm going out of time or anything, okay? So the biomarker, when you check your blood pressure for a patient, or blood sugar, or creatinine so creatinine is biomarker for a kidney function. Urine analysis and urine test is a biomarker of the kidney function. So we need a biomarker to see what's going on in our patients, at least to know exactly the bone resorption and the bone formation. So the optimal curve is to have your patient, bone turnover like here, not very little, not very high. Because if the bone turnover is little, the patient is getting aged. The bone is old. Like you remember progeria, when you see this young patient with senile faces. Same thing to the bone. You can have our 20-year-old dialysis patient with low bone turnover. His bone might be exactly the same as an 80-year-old guy, right? Very old, because there is no turnover, okay? There is no bone formation, there is no bone resorption. And bone micro cracks all the time, okay? And the bone heals itself with the bone formation and the resorption process. And you can see this bone is over mineralized. So even if you do a DEXA scan, you see, because the mineral is there, but the osteoblast is not functioning. It cannot lay out the osteoid, the protein, to form a bone. So it might be over mineralized. DEXA scan might be higher, and the patient might have dead bone. Okay. On the other hand, if the patient has high turnover bone disease, on the other spectrum, the patient can also fracture because of the bone resorption is very high, and he will lose bone. So we need a balance between both of this. Technically, like we are, as I said, tomorrow we're doing bone biopsy. So bone biopsy tell you exactly what's going on, okay? It's not only bone, we have also some details about bone biopsy. But if we talk about just regular bone histology, you can see in osteoitis fibrosa cystica or high turnover bone disease, this picture. Just familiarize yourself with. This is an osteoclast. We mentioned it before. Multinucleated giant cells. Actually, it doesn't come from the bone. It comes from the hematopoietic stem cells, from the macrophage, monocyte, macrophage, then, an osteoclast. It's very big, biologically active. And what it does, it induces something called the resorption bed. See this groove in the bone? This is a resorption bed. It already eaten this part of bone. Here is the mineralized bone. This is the normal bone, the blue part. This is bone, which is mineralized, okay? Here is the unmineralized bone. So these are a protein. This is a collagen. It's called osteoid, which is laid out by the osteoblast. See these cells, the 100 cells, the troops, the soldiers working together to build up bone. It lay out collagen. It lay out the protein, which is a collagen type 1, which is the matrix, okay? Then the matrix is like the mesangium in the kidney. Then on top of this matrix, the mineralization happens and crystals start to be deposited. And also you see fibrosis. This is the reason. So this is fibrosis, this is a bone marrow, and you see fibrosis inside, and resistant anemia and resistant to erythropoietin therapies, right? This is why we call it osteoitis fibrosa cystica, the old term. Osteoitis is like inflammation. There's a lot of cells. You don't see this, cells, see here is osteoclast, a lot of osteoclast, a lot of osteoblast, hyperactive bone, right? It's like when you see an abscess and you see a lot of polymorph. So it's osteoitis, like inflammation in the bone, which is not inflammation, but hyperactivity. Fibrosa, because there is bone marrow fibrosis, and cysta, because it induces cyst. Okay, and here is a picture of adynamic bone disease. Paucity of cells. You don't see cells. It's hypoactive. These are all adipocytes, and here are the bone. It's mineralized bone, old bone. You don't see the red. You don't see the osteoid, because the osteoblast, they don't lay out the collagen. It's inactive. Okay, so these are already formed bone from long time, and it's not renewed. It's geriatric senility bone, right? Then this is an example of, where is Mahmoud Sobh? This is an example of, this is very thick osteoid, right? And the osteoid volume is high. So the thickness and the volume is high. So which example is that? Osteomalacia, right? This is osteomalacia. Here's the problem is not in the osteoblast. The osteoblast is functioning. Actually, it's over-functioning. So you built up this collagen, you built up this osteoid, the unmineralized bone. Then the problem is it's unmineralized bone because either severe vitamin D deficient, we don't see this in adults anymore. This might be, Mahmoud doesn't know this because we don't see this very common now. We don't see, maybe less than 1% of our CKD patient has this osteomalacia, but we see it in children with severe hypophosphatemic rickets, severe vitamin D deficiency, severe hypocalcemia, we can see that. Then the mixed picture, one side with osteoitis fibrosa cystica or high turnover bone disease, and the other side with the thick osteoid. Okay, how can we use BTM, the bone turnover marker, because we are not going to do bone biopsy for every single patient, right? It's hard to do that, I understand. So we need to use non-invasive blood tests to replace or to give us idea about the bone non-invasively. Okay, so the BTM, the bone turnover markers, it's a blood test, and it helps you not only to diagnose bone loss and to predict the fracture risk, but also more importantly, helps you to understand the mechanism of bone loss, because there is bone formation marker and there is bone resorption marker. And it's very important because if you are following a patient for a treatment, so it helps you to establish treatment, what, treatment modality you want to go with, okay, what intervention, what, do you want to give anti-osteoporotic medication using anti-resorptive therapy or bone builders, right? Then you need to follow up the patient after establishing the medicine. If you wait for a year or two and do the BMD, DEXA scan, it's too late, right? But this helps you because they are quick. They are more, it gives you the biological activity of the bone faster in a couple months. The bone formation markers usually, bone formation is, as we mentioned, it's a longer term process, but bone resorption is very quick. So bone resorption marker can change in a month or two. Bone formation marker can change in 3 to 4 months or so. And here is the idea. So you need to get a good precision in DEXA scan, you need 2 years. And using BMD, the bone turnover marker, you just need a couple months, maybe 3 months. So let's focus simply on the most widely used BTMs, bone turnover markers we use. There is plenty of them. As I mentioned, bone formation marker, we have osteocalcin, we have bone-specific alkaline phosphatase, and we have B1NB and B1CB, okay? On the other side, bone resorption marker, we have also a lot of them, CTX, NTX, and the urine deoxyprotein and hydroxyprotein. And more important is the territory-resistant acid phosphatase, what we call it TRAP5B. The problem with CKD, most of these biomarkers are retained. They are excreted in the kidney, and in patient with CKD, they are retained, so their levels goes up. It doesn't only reflect the bone activity, but also reflects the degree of the kidney function and the clearance. But the TRAP5B is a bone resorption marker, and the bone-specific alkaline phosphatase, which is bone formation marker, they are not cleared by the kidney, okay? So you are not affected by the kidney function. This is the reason they are one of the most widely used biomarker to examine the bioactivity of your bone. Okay, if you see here, the bone-specific alkaline phosphatase has very good correlation with the bone biopsy, bone formation rate over bone surface. It's a bone biopsy parameters. But also, if you don't have that, you can just use total alkaline phosphatase, right? It's very easy. If the patient doesn't have a liver problem or not pregnant, because total alkaline phosphatase can come from the placenta, come from the liver. It's mainly coming from the bone. Then it wouldn't be changing, if the patient has stable liver function and not pregnant. But It's good, but of course there are the correlation is less. But if you cannot do the bone specific, at least focus on the total alkaline phosphatase, which is very affordable. And here a combination, if you use, thank you. If you the precision, the sensitivity, specificity, positive and negative predictive values of these turnover marker, if you use them in combination, so this is in conjunction. So you don't do only BMD, you don't only do alkaline phosphatase. It's a combination of things. If you want to be more accurate, more precise, you need to do more of these. If the BTH, the most widely used biomarker, is less than 200 and bone-specific alkaline phosphatase is less than 20, you absolutely have higher, very high prediction for low turnover bone disease. So it's very helpful to diagnose the mechanism of bone loss. Another example that you can do something called HRBQCT, high resolution peripheral quantitative CT. I know it's advanced. You might not have it here, but also it gives you the problem with the DEXA scan. It's 2D. It's 2-dimension, but the CT is 3-dimensional, right? So the problem with the 2-dimensional DEXA scan, we call it aerial BMD. It doesn't give you any information about the bone mass or the bone size. So it treats everybody. It gives you the content of bone, the density of bone in a single spot, okay? And it can be influenced also by artifacts, or, also by calcification, especially on the vertebrae. But the the QCT, especially the HRBQCT, the high resolution peripheral QCT, it's more accurate and precise, and it's 3Ds. So it gives you an impression about the volume and the size of your bone. Also, it differentiates between cortical and trabecular bone. So the DEXA scan doesn't differentiate between cortical and trabecular bone, right? So the reason that we try to put the cursor of the DEXA scan in the middle, which is mainly actually trabecular. So if the patient has a major problem in cortical bone than trabecular bone, it might give you, a wrong information. But the QCT or the HRBQCT, the high resolution CT, gives you also impression not only about the cortical bone and trabecular bone, but the connectivity of bone, the trabeculae of bone, if it is thin, if there is more cortical porosity, and more details about the bone. I don't want to scare you, but we are working on that. Mamdouh now is doing this work on FTIR. I am not going to, this is, we do this from the biopsy. This is an invasive. After we take the biopsy, we don't do only the histological part that we mentioned, that with the osteoblast, osteoclast, and osteocyte and this structure, but also we do further tests. We can do further tests. This is actually one of the good benefits of having invasive tissue, that you don't only do a histology, but based on this, you can do genetic study, you can do this advanced technique with micro indentation, nano indentation, FTIR, and you can do micro MRI. You take this specimen that we're doing tomorrow, inshallah, and you put it under a small machine, MRI machine, and give you more information and finite element analysis. I'm not going to talk about this. We are not bone specialists or experts, but I'm giving you that there is a lot of other tools that can give us more information about the bone. How much left in my talk? I think you're already bored. Okay, I will leave you with one or two concepts when it comes to intervention. I am not going to talk about the therapeutic intervention. I hate them. As long as I'm not getting money from the pharmaceutical company, I hate them. If they give me money, I will be happy with that. So I'll give you something about the non-pharmacological intervention, because everyone, when I especially come here, we are talking about advanced. How do you want to treat this patient? Just simple things. Okay, and simple things usually starts with what we eat and what we do. Okay, So what we eat is very important. And in America, they used to say, we are what we eat. Okay, if you eat healthy, you will be healthy. If you eat good, you will be good. Okay, but now they are moving. They are saying, you are what you eat. Okay, so you have not only to be particular about what you eat, but what you're eating. Like you're eating meat, cow, right? Like cow or goat or whatever. You go after this cow and see how these cows eat. Is this cow eating? Is she living in a healthy environment? And or if you are putting her in a small environment and covered, that she doesn't have sun exposure and she eats bad stuff, right? So naturally, this is even I remember, there was a fisher. The problem with this fisher, every time he went to the ocean to get fish, and it takes time for him to bring the fish and store it and deliver it to people. It takes a couple of days, so the taste of fish is bad. Okay, despite that, he's doing very good job and getting good fish, good catch. But when it goes to the customer, by the end of the day, it's not tasty. So he did multiple experiments, and one of the best experiments he has done, when he caught the fish, he put it in a tank and he put a shark in a tank. Of course, the shark ate 10–20% of the fish, but because the fish is trying to struggle and try to hide and try not to be eaten, right? So it's working all the time. So it's building up muscles. The muscles still flesh. When it goes to the customer, it tastes. So this is a challenge, right? This is how exercise, for example, or to be active will affect us. It doesn't only affect our meat, our muscles, but affect our bone and everything else in our lives. It's just an example. So what we eat, what we do affects us. There is something called obesity paradox in dialysis patients. I'm not sure if you are aware of this. Actually, obese dialysis patients, they live longer in multiple studies compared to the frail or thin people. So skinny dialysis patients, they live shorter, they die earlier. This is different. I'm not advocating that we need to advise our patient to be obese, but if you have a better nutrition, even if you are on the over nutrition side or overfeeding, it might be better compared to underfed dialysis. And there is a lot of explanation, but to be honest, I cannot see a good explanation so far. It might be because when they eat, one of the major things that I'm interested with, I'm just, this is just a speculation, is because sarcopenia is very bad. And when you get sarcopenia, you get osteopenia. It's called osteosarcopenia. You lose muscle mass, you lose bone right away. Muscle mass, you can see it, you can feel it, right? But you don't see the bone. The bone is the unheard, unseen part in our life. Then we don't see it till it fractures, right? So it's a major problem. So, but focusing on what we eat is very important. Even overnutrition might be better compared to undernutrition. Don't starve your patient, especially CKD patient before dialysis. We used to, I remember in Markaz Kela many years ago, there was lists, green list, blue list, and red list. Was that? Yeah. 60, 80, 40, 20, it was 20, yeah. وبعدين يقول لك تاكل لحمه قد علبه الكبريت. يعني of course, they will not be uremic, okay, faster. It takes longer time for them to start dialysis. But if you start your patient a year or 6 months earlier with good muscle mass, with good bone, he will survive longer. If you starve him to death, you delay the dialysis, he will say, this is a good doctor, but you're basically killing him. So it's when it comes to bone, same thing happens, because protein, as we said, the bone has 50% protein, the collagen. So if you malnourish your patient, if you're protein malnourished your patient, also the bone will get weaker. So this is one concept I want to leave you with. The other concept I want to leave you with is the exercise and the impact of exercise in our patient quality of life and survival. The problem with fracture doesn't only happen because we have weaker bone. It happens also if you have higher risk of fall, because you don't usually fracture if you don't have fall. It starts with a fall and then you fracture. Then if you have imbalance, if you have weak muscle, if you have problem with vision, problem with hearing, if you have unsafe environment. So when you have an elderly person in your home, you have to make sure that the rugs are not folded, they are straight. Maybe they have something to catch with or to hold their hand in the wall, something like that. They have to wear their eyeglasses. If they have hearing problems, they have to have hearing aids, because all of this contribute to the imbalance, then the fall, then the fracture, right? So what happens is the sarcopenia, if you lose muscle, you will have more imbalance, especially diabetic CKD patients. Diabetic CKD patients are the worst. By the way, patients with diabetes, they fracture with higher BMD compared to non-diabetics, okay? They don't have lower BMDs, by the way. The problem, of course, they have bone quality problem, but on top of this, even if they have okay bone quality and the quantity, still fracture because mainly of they have higher risk of falls, okay? And this is one of the reasons also that obesity might be protective from fractures. Obesity is bad for everything, but might be good for, do you have any obese person here? Should be happy now. So, obesity also is good for bone. Obesity, several studies showed virility is bad for the bone. Obesity is good for the bone. Not only because it improves the BMD and improves the bone quality, but also when they fall, this fat is a cushion, right? So they don't have this sharp fall on the hard ground. Hopefully this video will work. I'll just show you in dialysis. I don't know where is the voice. In dialysis, your patient on dialysis, he stays or she stays 3.5 hours, 4 hours on the machine, right? On the dialysis machine. I don't know, there's no voice here for some reason. But anyway, so what you can do is just to put them on ergometer or a cycler or something. While he's doing his dialysis, he can do exercise. He can do exercise. This improves our patient's quality of life. And I'll show you other studies. It improves the phosphorus clearance. It improves the bones, the BMD. It improves the mental status, the muscular status. It helps to avoid or prevent the osteosarcopenia. And it's very cheap. Even if you don't have a machine, I mean, you don't need to do this for so the whole treatment. If you have a small machine like that, you can use it for 5, 6, 7 patients at the same session, right? 30 minutes, 20 minutes, 15 minutes, they can share it, clean it, and use it with other. So anyway, so it's a very simple thing. Here, this article, they reported on impact of physical therapy in dialysis patients. And they said, as you see here, this was published 4 years ago, they said physical deterioration of dialysis patient ignored, L reported, L, not miss or under L, it means sickness or bad, it has this bad impression, and L treated, not mistreated or under treated. You can simply say under treated. But L treated, it's bad for our patient. You see, what they said is an editorial article, and they collected all the physical therapy article compared based on the risk stratified based on the disease they have, and you see the renal 0.4%. Among from 1,763 articles published or studies published on this field, only 7 included, renal patients. Most of these studies exclude renal patients, but because most of these studies were done by physical therapists and non-nephrologists. But for us, it's very simple. Instead of me talking to you about sclerostin and discussing very advanced, very expensive medications that has a lot of adverse effects, why not discussing, good nutrition, good quality of life, exercising? Try to talk to your patient, encourage your patient to move. Weight-bearing exercise is very, very important. It can have better and safer impact on our patients' bone health. There is a smaller, even when it comes to research, we have مدرسين مساعدين and so on, magister and doctorate. Don't do very advanced stuff. You can do simple like that. This is 40 dialysis patients randomly to exercise or to control growth. So 20 patients, they exercise and they have this cycler for 30 minutes. Then they repeated the BMD in 3 months. You cannot see any study on any medication that they do BMD in 3 months. At least 6 months, most of the study a year or 2, right? To see an impact of pharmacological intervention. But here, just in 3 months, you see the loss, the BMD loss in the control group. There is almost no loss, and in the exercise group, but in the control group, they lost bone. Here, the impact, this study actually was done on just 13 dialysis patients, okay? And what they have done, they did only exercise for 8 weeks. They divided them to 2 groups. One, they exercised, the other, they didn't encourage for exercise, and they crossed them over. So what they have done, they saw that the bone-specific alkaline phosphatase, the bone formation marker, improved markedly just in 8 weeks, okay? 8 weeks. Also, they did the season 125 vitamin D level, it's doubled from 46, the mean, to 80, a mean of 80, 87, 46, so doubled. If you give them vitamin D, they wouldn't have this effect. So the effect of exercise on vitamin D level, actually it was better than to give them vitamin D itself. Sun exposure, exercise, diet is much more important than medication. And also another study, very small study, 28 patients, they randomly to exercise group, non-exercise group, and you see the phosphate clearance improved. Instead of giving tons of phosphate binders, then the patient will have constipation, increased cardiovascular calcification with calcium, the calcium-containing phosphate-lowering agent. Just encourage them to exercise, especially if you have them, you are keeping them on your dialysis, clinic or dialysis unit for 3 times a week, at least 3 hours, with each treatment. Just encourage them to exercise, give them something. If you don't have anything, give them a stress ball. الكرة اللي بتاعت الفيستولا دي اديها لهم يعملوا exercise, ask him or her to do like a squeeze for 10-15 minutes, 4 or 5 times during the day. It's very simple, just encourage for physiological things. So in summary, bone health is not only bone quantity, but it's also a combination of bone quantity and bone quality. BMD assesses only the bone quantity, but if we add the TBS, the trabecular bone score, just add a software, ask if you have a machine, or if you are requesting a DEXA scan for one of your patients, and your patient comes in with the results, talk to the radiologist. Where is the TBS? Maybe he doesn't know, or maybe he doesn't care because nobody cares. Okay, but if you talk to him and say, "What is the trabecular bone score?" I hear that this is just a software. It's not adding any radiological exposure or extra cost or anything on our patient, and it's helpful to understand, not only the bone quantity but quality. He might be interested to buy it or to get it. Bone quality has major emphasis on CKD patients. So if bone quality is important in general population, it has more emphasis in our CKD patients. Before starting any intervention, especially therapeutic, please try to understand, try to think a little, what does my patient have? My patient have bone loss? Okay, I need to treat this bone loss. What kind of bone loss? Does it have high turnover, low turnover, osteomalacia, a combination of things before putting the patient on long-term therapies. Non-pharmacological intervention, it's easy, it's affordable. It's not only good for the bone, it's good for every single aspects in our life, okay? So it's good for our hearts, for our neurological system, for our musculoskeletal system, and beyond. Start early and integrate with your patient. It's not about prescribing. Sometimes I got a consult what to do. It's not about, you give a medicine. This is the easiest part and can be the worst part. The hardest part is to integrate, to listen to your patient, to have a dialogue with your patient and communication with your patient. Spend time with your patient, understand what exactly going on, try to encourage him to do the right thing rather than to give him a simple prescription. Even if you give him simple prescription, because you give bisphosphonates for a year or two, the patient might not take it regularly if he doesn't understand, because he doesn't see a direct effect, right? For blood pressure medicine or blood sugar medicine, he takes the medicine, he sees the blood pressure going down. And when he checks his blood sugar after taking the blood sugar medicine, or even he don't have to go to the bathroom at night. So he sees direct and very, very, quick response for other. But when it comes to bone, he doesn't see that. He doesn't see this till he fracture, then he dies, okay? So we need to be proactive, take initiative, explain our approach to our patient, try to make them more compliant and integrated in the healthcare system than to be just receiver to the system. They should be actively participating partners in our healthcare system. And thank you so much.